treatment of Pompe's disease, which is a deficiency of alpha glucosidase, has been approved for this treatment. In the same year, another enzyme, elaparase, was used for treatment of another mucopolysaccharide disease, the type 2, which is called the Hunter syndrome, and this also is now available. There are some studies going on, and interestingly, all these diseases that we are talking about, they are not done on the newborns alone. Newborns, if the damage starts occurring there, yes, of course they are required there, but sometimes the form of frustrae they manifest in the adult, and several of these studies are in the adult. And a new study that is going on is on the use of a replacement enzyme, a sphingomyelinase, deficiency of which causes Niemann-Pick's disease, and the replacement of this enzyme is being done in these cases of adult Niemann-Pick's disease, and the results are likely to come probably by the end of the year when it can become available.
I'm sorry to interrupt. There's a call from Jaipur.
Most of these enzymes.
Sir, there's a call from Jaipur.
Yes.
Yes, Jaipur. Please proceed with your question.
Can you ask your question or give your comment? We can't hear you.
I think it got disconnected. Please proceed, sir.
Now, most of these enzymes are recombinant human kind of enzymes, and they do have some side effects because they have to be used regularly, weekly, monthly, daily, depending on the disease, and one has to give them under medical supervision. But they hold some kind of a treatment for these otherwise untreatable diseases, and it may be pertinent to mention that other modalities of treatment are being explored or used for these lysosomal storage disorders, which may either be enzyme substitution or enzyme expansion or a gene transfer as a mode of permanent cure. The next advance I would like to mention about is something of great clinical importance, and that is relating to the blood transfusion. We are always short of blood in our country, and I think the world over there is a deficiency because the demand for blood is increasing more than the number of donors that are coming in. So there has always been a thought and a research on how we can meet this increasing demand. The so-called artificial blood has been talked about for a couple of decades, starting with the time when perfluorocarbons were thought to carry a lot of oxygen with them. Perfluorocarbons are hydrocarbons where the hydrogen is replaced by the fluorine. They are like the Teflon coatings we see in our kitchen. They have great affinity for oxygen, and Flusol DA-20 was approved by FDA quite some time back, but was given up because of its toxicity. Now there is a new liquid variant which binds oxygen, and that is Oxygent, that is being tried. So there are chemical based oxygen carrying molecules for use as artificial blood. Equally important are certain hemoglobin based oxygen carriers. These are the ones where hemoglobin is the base and not a chemical compound.
There's a call from Jaipur.
Please go ahead.
You can ask your question.
Hello, Jaipur. Please proceed with your question. Hello. I think it again got disconnected. I'm sorry for the.
We will wait. If it comes through, we'll take them up. Meanwhile, apart from these liquid agents, which are oxygen carrying agents, hemoglobin based oxygen carriers have been used. Hemopure is a form which is derived from bovine hemoglobin and has been marketed for the past couple of years in South Africa. In fact, it is available and it is used. There were some apprehensions elsewhere whether it would be a good substitute for the blood. The US has done a lot of studies on the Hemopure, which is the bovine derived hemoglobin, and all these results are likely to come by the second half of 2007 when it would be clear whether it can be made available on a wider scale, or at least it will be available in US and Europe or not. Meanwhile, polyheme is a polymerized form of human albumin. It is polymerized using a glutaraldehyde, and this polymerized form carries the oxygen pretty well and has been in use, and there are studies that have shown its benefit, and it keeps getting used from time to time. In addition to the availability of these artificial blood, one has always talked about expanding the blood, whether using the autologous blood, and this autologous transfusion is used by so many surgeons for for the benefit of giving the same blood as the patient's own, and this is done using erythropoietin or other growth factors to stimulate the increase of to increase the production of blood, which is then stored and given few days later at the time of surgery or following the surgery. There has always been work going on using these stem cells, whether they are derived from the peripheral blood or from the cord blood. If they are used from the peripheral blood, then the stromal cells are missing. So one tends to use these stem cells, hematopoietic stem cells, and give them an environment which is akin to bone marrow environment. Now, bone marrow has got two kind of stem cells. One are the hematopoietic stem cells. Another one is a stromal cell, which are basic meshwork on which these stem cells work. So by providing this stroma, the stem cells have been used, and a growth factor added to that is supposed to increase the yield. Unfortunately, in the lab studies, we have not been able to propagate these stem cells indefinitely. So the blood demand cannot be met, but it is a good source, and one can keep thinking whether it would give greater yield in times to come. An interesting work was reported this month by the Danish group, wherein the please go ahead.
We have a call from Jaipur again. I hope it gets connected this time.
Hello.
Hello, please ask your question.
Hello.
Hello.
We are able to hear you. Proceed with your question.
Hello.
Hello.
Yes, sir. We
Hello.
can hear you, sir. You please ask.
Hello.
Please ask your.
Hello. Hello.
Hello, please ask your
Hello.
question.
Khade.
Hello.
No, just for fun.
I guess there's some problem with the connection. So please proceed. If anybody has any query, please call us on our toll-free number of 1800 112345.
Minimum and maximum.
Please proceed with the session, sir.
Hello.
Hello.
हेलो सर जी आवाज नहीं आ रही कौन बोल रहे हैं
Hello. Please proceed with your question. आप अपना question पूछिए.
Sorry, sir. Proceed. It's a
Proceed.
disturbing call. लगता है.
Now, another ingenious thing that has come up this month is regarding the universalization of the blood group, which means blood group cross matching may not be required. As this picture shows, the one on top showing the O antigen shows the basic structure of the glycosyl moiety that is attached and that is responsible for the blood group. This is common to all. Down below on the left is a B antigen which carries a galactose moiety, and on the right is a acetyl galactosamine moiety. What has been done is these extra moieties of glucose related compounds, these are deleted by using an enzyme. This kind of a thing was thought of and tried earlier, but no consistent success was seen. Now, using two bacterial enzymes, one is the Bacteroides fragilis that we keep seeing, and one is Elizabeth Kingia meningosepticum. Their enzymes have been used to slash off the galactose and the acetyl galactosamine moieties, thereby producing a common O antigen on all the red cells. So, using this enzyme, one hopes that the red cell requirement for any patient can be met, because any other group can be converted into a equivalent O antigen RBC. This particular technique will not look after the problem of RH incompatibility. The next one relates to the implications of pharmacogenetics in clinical medicine. The pharmacogenetics refers to the genetics of an individual, the genetic makeup of an individual, and as it is relevant to his response to a given pharmacological compound, that means a drug. And we are realizing that the same drug, one dose does not fit everybody, and this is no longer true. There are many drugs in the pipeline, but I'll take up warfarin as a case study, because warfarin is the one which probably will lead the scene of pharmacogenetics in clinical practice, and it is coming up so fast that FDA is likely to put such labeling that pharmacogenetics be done for patients who are going to consume warfarin. The background of this particular implication is that warfarin is a compound, an anticoagulant compound, a coumarin derivative compound, which is used very widely by the cardiologists, the vascular surgeons, the physicians, and everybody for its anticoagulant effect. It is used on a long-term basis. The benefits start from the day one when one starts using it, and the sooner one can titrate the dose in the beginning, the better the long-term effects also. However, one finds that there is a large dose variation for this drug with a small therapeutic window. The dose variation is 1 to 10 milligram, but we see beyond 10 milligram, 15, 18, 20 milligram with not as much of benefit, whereas with 1 milligram one develops the side effects. The races also have different sensitivity. The Afro-Americans are the least sensitive to the pharmacologic effect of these drugs. Now, these things have got great implication, and one of the greatest implication is when we look at all adverse side effects of all drugs that we use, we find that 15% of them can be accounted for by warfarin alone. It is second to digoxin only. And the second one is when one is trying to optimize and titrate the dose in the beginning, it can need as much as a month or even more to get to the regular dose, and this is a loss of time when the thrombotic pathology can cause a lot more damage. It is usually titrated by doing the prothrombin time or the INR, but we find that it is in the targeted range only at half of the occasions. The problems seem to crop up from the fact that coumarins, including this warfarin, is metabolized through the liver, and in the liver the metabolism is done by one of the cytochrome P450 enzyme. This is the CYP2C9 enzyme. This enzyme is highly polymorphic. 1/3 of the population is thought to have a variation that is supposed to decrease the that is supposed to have less metabolic effect on warfarin. That means they are prone to toxicity at a given dose. This cytochrome P450 enzyme, that is 2C9, is almost exclusively responsible for one of the racemic isomers of warfarin. Warfarin is found in two racemic forms, S and R. So it is looks after the S, which is also incidentally 3 to 5 times greater in its pharmacological potency. Now with this kind of a variation, one finds that cytochrome P450 2C9 variant, which is a common enzyme, has got a large polymorphism amongst the population. And if we can know about that polymorphism of a given individual, we can titrate the dose and prevent the side effects, especially the serious side effects of this particular drug. In fact, 2006 the draft manual for such labeling has already come out, and it is possible that one of these days we will have warfarin leading the scene of the use of pharmacogenetics in clinical medicine. It will be pertinent to mention that some degree of variation also comes from the another genetic part of the human body, and that looks after the enzyme through which warfarin acts, that is the vitamin K epoxide reductase, and vitamin K epoxide reductase complex 1 is also variable. So the two have to be seen in conjunction and together to get the best benefit of using the optimal dose of warfarin in anticoagulation. The next advance relates to the use of thrombolysis in cerebrovascular strokes. Strokes can be ischemic, hemorrhagic, excuse me. Now in ischemic strokes, attempts have been made to use thrombolysis, and actually it is accepted for certain forms of stroke. It's very strange that for ischemic heart diseases, thrombolytic therapy has been used on a much larger scale for a much longer time. But that was not the case in strokes because of the risk of hemorrhagic transformation even in a ischemic stroke. However, the recombinant TPA has been approved for intravascular use in cases of ischemic stroke, provided it is used within 3 hours of the onset of stroke symptoms. The sooner we use, the better the benefit. A meta-analysis showed that the benefit within 90 minutes is the best, and it gives rise to a benefit which is threefold compared to those cases where if it is not used. The life after the stroke is much better if it is used within 90 minutes of the stroke, even though the benefit odds ratio of 1.4 up to 4.5 hours shows that this benefit will persist even up to 4.5 hours. These studies were done up to 6 hours, but I think the benefit will be up to 4.5 hours, but sooner the better, so one must act early. All these odds ratio translate into a fact that out of every 100 patients, almost 1/3 will have a better outcome if thrombolysis is used in stroke. At the same time, about 6% will suffer a hemorrhage, which comes to about 3 out of these cases that will have the hemorrhage, a serious hemorrhage. This risk of hemorrhage can be minimized by taking special care, especially when using it in old age where most of the strokes are, or using it in extensive infarct. Extensive infarcts is a dual-edged sword. The benefits are more there, but then the risk also is more. Or using in a situation where there is diabetes with high blood sugar or a previous history of stroke or a thrombocytopenia coexisting with this. The usual exclusion criteria as used for the coronary ischemia are also to be applied when using thrombolytic therapy in cases of stroke. I think I'll stop here because I'm being told the time is coming to an end, but we will take up questions quickly if they can come through.
If there are any questions pertaining to the topic, please call us at a toll-free number of 1800 112345. We are waiting for your calls. The next session would be at 12 p.m. and the topic would be recent advances in the field of surgery. Any questions pertaining to this topic of medicine, you can put forward the questions in the next session also. Dr. Naresh Gupta would be with us. 1 minute still left. Please ask any questions if you have. So it was a very enlightening session. Thank you very much for sparing your time.
Thank you. I hope the listeners found it beneficial.
Oh, I'm
But
sure so.
there were some questions that were coming in. For some reason, we could not get through.
I guess there was some connection problem. We would look to it that it doesn't happen again in the next session.
But I can just mention one more thing. These days, the medical advancements are affecting even the non-doctors, that means the common man. And if one is aware of good media, one would find that these advances are making way into the everyday audio-visual media, and one can pick it up from there also and take up the detailed issues from the concerned journals or the reviews. There are some very good journals that are coming in, and for medicine, apart from our own journals.